Good afternoon, everyone, and welcome to the Arizona Center for Rural Health State Office of Rural Health webinar series. My name is Mariah, and I will be your host along with our wonderful speaker today. Next slide. A couple notes for the webinar. The audience is muted throughout the presentation, but we ask that you put your questions in the chat box so that they can be addressed at the end of the webinar. As well as there's a post-webinar survey that goes out. This really helps us make sure that our content is addressing what you guys want to hear. And lastly, the webinar is recorded and will be posted. So if you find this information helpful and want to share it with others, please do so that way. Next slide. I'd like to take a moment to respectfully acknowledge that the University of Arizona is on the land and territories of Indigenous peoples. Today, Arizona is home to 22 federally recognized tribes, with Tucson being home to the O'odham and the Yaqui. Committed to diversity and inclusion, the university strives to build sustainable relationships with sovereign Native nations and Indigenous communities through education offerings, partnerships, and community service. And with that, I will hand it over to our wonderful speaker today, here to talk about pediatric eye care, Rizwana Biviji. Thank you.
Thank you so much for the kind introduction. Good afternoon, everyone. I'm very excited to be here. I'm Rizwana Biviji, an assistant teaching professor at the College of Health Solutions at Arizona State University. And I will be presenting some of our results from our study, which is titled Closing the Gap in Pediatric Eye Care, a Network Adequacy Study. So this is our dedicated research team here at the College of Health Solutions. And I do want to mention that this study was funded by Virginia G. Piper Charitable Trust and commissioned by Eyes on Learning, which is a non-for-profit organization in Arizona. So did you know up to 28% of Arizona's children have vision problems that may impact their ability to learn, develop, and acquire literacy and reading skills? Pediatric vision services are crucial for improving eyesight, discovering diseases early, and enabling educational success. 1 in 20 preschool and 1 in 4 school-aged children experience vision challenges. Therefore, CDC recommends that children should be examined between newborn to 3 months, 6 months to 1 year, 3 years, and 5 years. And then school-aged children are recommended to be screened every 2 years. Yet, disparities in screening and access to services persist, especially among children from low-income and racial ethnic minority backgrounds. More specifically, Arizona children aged 0 to 17 years receive vision screenings at rates below the national average. Limitations also exist among the insured related to cost, accessibility, and inadequate networks. Therefore, having adequate networks are very important as they facilitate access to routine and recommended eye care services for children, and is imperative to achieve overall improved health outcomes, educational attainments, and can ultimately reduce health disparities. So this study aims to determine where pediatric vision care network adequacy exists in the state of Arizona and where there are gaps in receiving vision care for children. We defined network adequacy by the extent services are available by region, type of care available, optometry versus ophthalmology, payments accepted, that is the insurance type, ages served, and languages in which these services were offered. So in terms of our data set, the data set of practicing pediatric eye care providers in Arizona was built using existing databases from the Arizona Medical Board, Arizona Osteopathic Board for DO, and Arizona Board of Optometry for OD data. These databases were further cleaned to include only those providers who were active, licensed in the state of Arizona, and specializing in ophthalmology or optometry. Next, we merged and deduplicated the data across all 3 practices. From this, we organized the data to consolidate all providers who were working in the same practice to one address. This is because we wanted to convert our data set from the provider level to the practice level. So this process resulted in a total of 703 unique practices in the state of Arizona. Now, one thing to note here is that we had to conduct an additional step to clean the data set that we received from the Arizona Board of Optometry, where a large number of providers had recorded their residential address under the mailing address designation within the database. So therefore, in order for us to accurately categorize providers licensed in the state of Arizona, we had to manually enter their names into Google and identify each provider's official mailing address and office location. So now the variables that were included in this study, so there were 11 variables that we mainly focused on, which include time until the next available appointment, time of day for appointment, after hours and weekend appointment availability, whether the practice was reached, whether the practice was accepting new patients, whether the practice was accepting a specific insurance plan, whether the practice was offering online booking options, bilingual services, the region of practice, ages served, and if the patient needed referral from a primary care provider in order to be seen. So in terms of study design, this is a cross-sectional study using a secret shopper phone survey, where we contacted each individual practice using a standardized script to schedule routine appointments, posing as parents of a 10-year-old and a 3-year-old patient or child. So in a way, we were mimicking the real world experiences of a parent who's wanting to schedule routine vision care appointment with their provider. Now, why secret shopper methodology? Well, this methodology is considered to be more cost effective as opposed to customer surveys or even having structured interviews with office staff. It is also the existing literature suggests that this is an ethical approach, especially to evaluate programs such as Medicaid. And then most importantly, it eliminates what is called as the Hawthorne effect, where individuals, in this case office staff, may alter their behavior when they're aware that they are being studied. So overall, we found that the secret shopper methodology allowed us to collect sufficient data even with limited resources. Now, AHCCCS, which is the Arizona State Medicaid program, contracts with 7 integrated managed care organizations or MCOs across 3 geographical service areas in Arizona, that is North, Central, and South. So for the purpose of our simulations, we chose the most prominent MCO within each of the 3 GSAs, that is Mercy Care for Central, Care First for North, and Banner University Family Care for South GSA. Similarly, in terms of commercial health insurance, we chose Blue Cross Blue Shield of Arizona and Oasis while placing calls to ophthalmologists and optometrists respectively. For our survey instrument, we used a standardized script that included questions such as appointment availability, patient intake, and then we wanted to further capture the most comprehensive information from each call. Therefore, we had detailed field notes that were recorded during our conversation with the scheduling staff. Now, these field notes were a summary of the key takeaway points from our conversations with the office personnel. Further, to test the validity of the survey instrument, 2 research assistants made 100 calls each, posing as a parent with access and 1 with commercial health insurance. So in terms of calling procedure, 5 research assistants were trained to pose as secret shoppers, and they placed 1,406 calls to 703 practices between May to June 2022. Therefore, each practice received 1 call from a parent of a 10 and a 3-year-old child enrolled in AHCCCS, and then 1 call from a parent of a 10 and a 3-year-old child who was enrolled in commercial health insurance plan and wanting to schedule a routine eye exam. So afterwards, we excluded those practices from further analysis where we could not reach even after 3 attempts, who had inactive providers, where our calls were truncated due to requested identifying information such as social security number or insurance number, since we could not provide that as we were posing as parents, and also excluded those facilities that did not offer routine eye exams and were strictly a surgical or a specialty center. So this process resulted in a total of 556 practices from the access side and then 510 practices from the commercial health insurance side. So in terms of data analysis, descriptive statistics, that is mean, range, and frequency, were calculated for all of our variables. Next, an independent t-test was used to study the mean difference in appointment wait time at the practice level for children that are covered under access versus commercial health insurance. So we mainly wanted to see if there were any significant differences in the wait time between these two insurance types. So the outcome variable, time until the next available appointment or wait time, was based on the number of days one had to wait for their appointment. And this was calculated by subtracting the date of when we received the appointment from when the call was made. And the statistical significance was set at p less than 0.05. Next, the field notes from a phone survey were analyzed using a general inductive content analysis approach. And this approach, within this approach, the themes were derived from the data itself as opposed to using preconceived categories. So looking at our results, the first being access to care. Now, I do want to highlight that the state of Arizona is predominantly rural, with several counties designated as medically underserved areas by the Arizona Department of Health Services. So this MUA designation is given to counties with limited access to primary care services and primary care physicians. So similar to what we see in terms of MUA designations, we also found a higher concentration of providers in more of the urban counties, such as Maricopa and Pima, while rural counties like Apache, Greenlee, La Paz have single or no providers. Further, 61.3% of the providers were serving children aged 18 and younger, and more specifically, 41% of the providers in the state serve pediatric patients 5 and younger. However, counties such as Apache, Cochise, Gila, and Santa Cruz have single or no providers serving very young children. So in terms of patient intake, it is very important that a smooth patient intake process is required to ensure that there are no scheduling appointments and everything goes hassle-free. So there are several factors that play a role, including whether a practice is accepting new patients. So the good news is that most practices were open to new patients. However, there was a clear difference based on the insurance type. That is, we saw that 90.4% of practices told the commercial insurance caller that they were accepting new patients, compared to 78% for the access caller. Some of the common reasons for not accepting new patients included provider unavailability, specialty focus on certain medication, certain medical conditions, or not serving pediatric patients. Next, as high as 69% of practices were accepting the stated commercial health insurance, that is Blue Cross Blue Shield of Arizona or Oasis, while only 26% accepted the access that we mentioned during our calls. A majority of practices did not require referrals from a primary care provider for routine eye exams, with only 8.7% requiring a PCP referral for the access caller. Now, online scheduling offers a convenient way to book appointments, and therefore we were very interested in seeing whether these practices were offering online scheduling options, especially for those individuals who work during business hours and may not have the flexibility to call a provider during those times. So what we saw was that around 56% of practices informed the commercial health insurance caller that they have online scheduling options available versus 43% to the access caller. Similarly, we saw that as high as 59% practices reported offering bilingual services to the commercial health insurance caller versus 46% to the access caller. Now, this variability in the numbers for the online scheduling and bilingual services across the two insurance type could be due to the fact that our calls were fielded by different office staff who may have varying levels of knowledge related to the types of services being offered. Or it could be due to the fact that they were just overall more accommodative of requests that were made by commercial insurer versus the access caller. Next, we talk about appointment availability. And in general, long wait times to see the provider may act as an access barrier in seeking timely care. So what we saw was that the average wait time for the next available appointment was 13 days across both insurance type. So overall, on an average, one would have to wait for 13 days to set a routine eye care exam for their child. However, we did not see any significant differences in the appointment wait time between the two insurance types. So we were mainly wanting to note if there were significant differences, and we did not note any significant differences in wait time across these two insurance types, which was good. Overall, the wait times were in the range of 0 to 97 days for access callers, which means that at least 26 practices were in direct violation of Access Contractors Manual or the ACOM Policy 417, where routine appointments should be made available within 45 days of request. And we also saw that urban counties of Coconino, Maricopa and Pima had an average wait time of less than 2 weeks, while the rural counties of Gila, Mojave, Santa Cruz, Yavapai, and Yuma had average wait times of greater than 4 weeks. So again, talks about disparities between the urban and rural counties. So next we talk about challenges in scheduling. And these were the qualitative responses from the scheduling staff that we had recorded and analyzed. And then they are further grouped into 7 major themes, which are listed over here in the order of occurrence from most to least frequent. So the most frequently observed theme, or what we were most interested in, was centered around ages served. Therefore, more than a third of our conversations with office staff focused on which age groups their practice was serving. And we were mainly wanting to see if the practice was serving very young children, that is less than 5 years of age. And we saw that some providers were seeing children as young as 6 months old. But for kids under 5 years, the availability is often limited to very specific times and then certain locations. For example, we see in this case, one of the quotes was, "We see patients as young as 3-year-old, but the provider is only in the office for routine eye exams once a month." The second most common theme from our field notes was insurance limitations. Now, in many cases, practices outright denied accepting the stated insurance. And this was far more common for access holders than those for the commercial health insurance callers. So for example, we see that a facility is medically contracted with access, but not visually. So you needed to have a medical condition in order to be seen, even for a routine eye exam in this case. The third most common theme we identified was language limitations. Now, Arizona has a diverse population, which brings unique language needs when it comes to communicating with healthcare providers. With a high Hispanic population, many patients feel more comfortable speaking in Spanish with their care team. Therefore, about 1/4 of our conversations focused on bilingual services, and we noticed some limitations and challenges from the provider side in meeting those needs. For example, in this instance, we experienced that the wait time for a bilingual provider is a lot longer and ends up being 2 weeks away. Further, facing obstacles in scheduling appointments proved to be substantive access barriers. Some of this pertains to long wait times to see the provider. For example, we are unable to accept new patients until the next year. So very long wait in this case. So outside of everything that I talked about and mainly focused on challenges, there were also instances where we encountered practices where everything was very smooth and the scheduling process was relatively hassle-free. And in these cases, the receptionists went out of their way to accommodate our requests, making the experience much easier. So it was definitely much more promising and hassle-free to schedule appointments when the receptionists were more receptive of what we were wanting and more accommodative of our needs. And these practices tend to offer care for children under 5 years, provide bilingual services, accept the stated insurance plan, and often did not require referrals from PCPs, all of which contributed to a more accessible and patient-friendly experience. So for example, in this case, a referral is not needed for patients less than 21 years old for routine eye exam. However, if it is a medical problem, then a PCP referral is needed. So coming back to barriers, another barrier to scheduling routine eye exams was rude or unhelpful office staff. And this was especially noticeable when a practice did not accept the stated insurance, with access patients experiencing this more frequently. Now, such interactions can make the appointment process even more challenging for those who are already facing insurance limitations. So this is kind of a two-pronged process, right? Like to experience uncivil receptionists also adds to further barrier when seeking out care or making appointments. So for example, in this case, we were told, if we see you, we would be seeing you assuming that you are unable to pay. And then finally, provider limitations. Here we observed inconsistent provider availability in a few instances. For example, our physician retired sooner than expected with a wait list going into August or September of 2022. So this is almost a 3 to 4 months wait time because most of our calls were conducted during May and June of 2022. So based on our findings, we recommend the following 7 changes. First being serving all ages. Providers and practices holding themselves out to serve children should include all ages of pediatric patients so that families can meet the CDC recommended screening guidelines. Second, accepting all insurance carriers. We recommend providers and practices to accept all vision and eye care plans, especially those providers serving vulnerable and low-income children, such as Access. Third being increasing language services. Providers and practices are encouraged to offer consistent language translational services. Next is improving patient-friendly interactions. Providers and practices should ensure that potential patients are not subjected to rude behavior or incivility by office staff answering calls. Therefore, we recommend offering trainings focused on cultural competency and humility. Fifth is easing barriers to scheduling. Providers and practices in Arizona should make efforts to ensure minimal barriers to scheduling appointments for services such as reducing the wait times, offering online scheduling options, and offering weekend and after-hours appointment for working families. We also recommend minimizing out-of-pocket costs because in many instances, we noticed that the out-of-pocket costs were as high as $500. So it would range anywhere between $50 to $500, especially if your insurance did not cover that. So we recommend minimizing those out-of-pocket costs and then further improving availability of providers. Our study should be viewed in light of certain limitations, first being accurate provider lists. So as discussed about before earlier in my presentation, I did mention that the optometrist licensee data did not require that the providers list their office addresses, which resulted in a mix of residential and office locations. So to ensure accuracy, we took extra steps to verify correct office addresses and phone numbers by going into Google and obtaining the most up-to-date information. So there may be some variability based on whatever was available online in terms of the most accurate or updated information. Next is that we made multiple attempts to contact the Arizona Osteopathic Board through various channels to obtain the most current DO dataset, that is for the year 2022. However, we were unsuccessful in obtaining the dataset from 2022. So as a result, the osteopathic ophthalmologists that are included in this study were sourced from a 2019 list, which we already had for a different study. So that was the most recent available data that we had at the time of data collection. Next, practices utilized a wide variety of operating hours and availability by phone. So even though we were calling the facilities between 9 to 5 or business hours, we did observe that practices had varying lunch hours, and in certain instances, especially on Fridays, some of the practices had shorter working days. So this kind of limited our availability to catch hold of them. And in some cases, it was difficult to connect despite multiple attempts on different days and times by our researchers. And lastly, due to the complexities in providing adequate information for the intended survey, IHS or Indian Health Services and VA or Veterans Affairs operated facilities were excluded from the study, except for one IHS contractor that provided us information. So this was mainly because whenever we called the IHS or VA facilities, we were asked for sensitive information or unique identifiers like social security numbers or service numbers, which we could not share. And therefore, obtaining data from these providers was not feasible, and we had to exclude them from further analysis. So in terms of conclusions, provider shortages in rural counties exacerbate pediatric eye care issues among medically underserved populations. Practices not offering Spanish bilingual services, either via staff member or remote translation options, reflect a gap in meeting the community's needs. And providers should ensure minimal barriers to scheduling appointments for services by offering an answering service, online scheduling options, same-day callback, and increasing the capacity or operating hours to reduce wait times. Now, I'm very excited to share that our study's findings, combined with the efforts led by Eyes on Learning, played a key role in the passage of a new law that expanded vision screenings to approximately 500,000 students in Arizona public and charter schools starting this past year. So that was very exciting. As I shared, there are disparities when it comes to accessing routine vision care services, especially in rural areas. So having this new law mandating schools to offer vision screenings is a great next step to reducing those disparities and barriers. So with that, here is the QR code to access the full text for our article. I believe this has already been shared anyways, but if you all wanted to review the article as well as the report. So if you all wanted to read through the report is available on the Eyes on Learning website as well. So with that, I thank you all very much for your time and open the floor for any questions.
Thank you so much. And yes, the full report or the article has been posted on our website and will be posted again with this recording. I did have one question that came through the chat box, and they were curious. You mentioned that the IHS and the VA facilities were excluded from the study for further analysis. Were they originally included in that map that showed the number of facilities by county? They were.
So, yes, that's a good question. So there are the map, I think the one that you're referring to is this map, the access to care map. So this map is at the provider level, and we just included all of the providers because it was at the provider level at this stage. So all of the providers were included at this stage. They were excluded when we further collapsed our data at the practice level and then made those calls. So yes, originally we included IHS and VA facilities even within our sample of 703. Going back to that data set. So this 703 practices included IHS and VA facilities, but then they were later on excluded since our calls got truncated. Like we couldn't make a leeway with them, so we had to ultimately drop them off. Thank you for the question. And I hope that answers the question.
Yes, thank you so much. That was the only question that came in the chat. I'll give it another minute, in case anybody has anything, but you did provide your email at the very end, I believe. So is it okay if they reach out to you one-on-one if they have any further questions?
Absolutely, I would love that. So please feel free to reach out. My contact information is rizwana.bvg@asu.edu. And please feel free to share that as well. And I'm happy to field any further questions via email or even have conversations via Zoom if there is a follow-up question related to our study.
Perfect. Thank you so much for your time today, and thank you everyone for joining us. And again, please reach out if you have follow-up questions or you want to read that entire article. Thank you. Have a great
Thank
day.
you for having me here. Bye-bye.